Neuroconduction Study Part 8 Generalized Peripheral Polyneuropathies. Neuroconduction studies are the gold standard tool for evaluating generalized peripheral polyneuropathies, that is, widespread nerve damage. They help clinicians in four major ways. 1. Confirming the diagnosis, that is, outright endorses a polyneuropathy diagnosis or points towards alternatives like small fiber sensory neuropathies or isolated nerve entrapments. Second one, it identifies affected fiber types, that is, pinpoint exactly which fibers are damaged, large fiber sensory, motor, or both. Third one, uncovering the underlying pathology. It determines whether the root issue is axonopathy, that is, damage to the nerve wire itself, or myelinopathy, that is, damage to the protective coating of the nerve. Finding the cause. It helps identify the pathology, drastically narrows down what is the cause of disease. Axonal polyneuropathies or axonopathy, the mechanism, it causes a length-dependent dying back degeneration of the nerve. The longest nerve fibers, those traveling all the way down to the feet and toes, will die first. Key NCS findings are: the big clue is a significant drop in CMAP and SNAP amplitude and area. This drop is most severe in the lower extremities. The spared features are conduction velocities, that is speed, and distal latencies, the time it takes for a signal to start moving, usually remains normal. The exception for this sparing is if more than 50% of the CMAP amplitude is lost. The fastest conducting fibers are gone. So, this massive loss can secondarily slow the conduction velocity down to 70 to 80% of the normal values, even though it's primarily an axonal issue. Demyelinating polyneuropathies, that is, myelinopathy. Mechanism: the damage to the myelin sheath impairs saltatory conduction, the way electrical signals normally hop quickly down the nerve. This causes a widespread delay in the electrical signal travel time. Key neuroconduction study findings are significant slowing, that is, conduction velocity drop below 70% of the lower limit of normal, and prolonged delays, that is, distal latencies stretch out to greater than 130% of the upper limit of normal. Effect of distal stimulation. It shows prolonged distal latency and moderate drop in CMAP amplitude due to temporal dispersion and due to phase cancellation, that is, signal arriving out of sync and cancelling each other. Effect of proximal stimulation. It pulls back an even lower CMAP amplitude or area with significantly slower velocities. Because the signal travels a longer distance, it encounters more demyelinating speed bumps, increasing drop-off and causing a possible conduction block, where signal stops entirely. Inherited versus acquired demyelinating polyneuropathies. Neuroconduction study metrics are highly effective in sorting chronic demyelinating issues into two distinct categories. First category, inherited. Example, Charcot-Marie-Tooth disease type 1. Here, uniform slowing is there. The myelin sheath is uniformly poorly formed. The slowing is identical across all the different nerves. Symmetry. The results in highly symmetrical abnormality. No blocks. Conduction blocks are characteristically absent. Acquired demyelinating polyneuropathy. Example, CADP. Non-uniform slowing. That is, the immune system attacks the myelin in patches. This creates asymmetrical nerve conduction result even if the patient feels weakness symmetrically. Conduction blocks. Multifocal conduction blocks, that is, signals getting stuck mid-nerve, are highly characteristic. Location. Severe Temporal dispersion happens at non-entrapment sites, that is, areas where the nerve is not just naturally squeezed by the anatomy. Acute inflammatory demyelinating polyneuropathy, that is AADP. AADP is the most common form of GBS. Its representation on an NCS evolves quickly over the timeline of the illness. Timeline of detection. Multifocal demyelination criteria are met only in 35 to 50% of patients in the initial first 2 weeks. By week 3, it is evident in 85% of cases. A unique diagnostic clue where upper extremity snaps are abnormal, but sural snap in the leg remains completely normal. This rules out typical length-dependent axonal patterns, which always hit the legs first. Diffuse absence of F waves. F waves are entirely missing even when standard motor conduction studies are normal. This proves the disease is attacking the very top of the nerve path, the proximal peripheral nerve, that is, spinal roots. This figure demonstrates the pattern of decline in the nerve conduction amplitudes after an acute axonal injury. Immediately after an acute axonal injury, day 1 and 2, both the CMAP and SNAP amplitudes are relatively preserved because distal portion of the axons are still intact. As Valerian degeneration progresses, CMAP amplitude decline earlier and more rapidly beginning around 3 to 5 days. SNAP amplitude decline slightly later, becoming markedly reduced around day 6 and 10. By around days 10 and 12, both responses become severely reduced or absent. Clinical significance. This explains why early nerve conduction studies performed within the first few days after axonal injury may appear normal. Repeat studies after 1 to 2 weeks better demonstrates the extent of axonal loss. Important electrophysiological point. In proximal lesions, example radiculopathy, snaps may remain preserved because dorsal root ganglia lies distal to the lesion. In peripheral axon neuropathies, both CMAP and SNAP amplitudes decrease after Valerian degeneration occurs. So, the days of injury and electrophysiological change. Day 1 to 3, CMAP and SNAP may still be normal. Day 3 to 5, CMAP starts reducing. Day 5 to 10, SNAP progressively decreases. Day 10 to 14, maximal reduction due to Valerian degeneration. In this image, in the panel A, all the nerve fibers appear intact and continuous. The impulse travels uniformly along all the fibers towards the recording site. Because the impulses arrive together, the recording waveform is sharp and large. The upper and lower part of the panel A demonstrate stimulation at different locations of the nerve. Despite the change in stimulation site, the waveform morphology remains similar. This indicates normal transmission of impulses through the nerve fiber. The waveform shows beneath in panel A are well formed, high in amplitude, synchronized. This reflects normal conduction through the peripheral. In panel B, several nerve fibers are interrupted and do not conduct the impulses. Only a small number of fibers continue to transmit the electrical signal towards the recording site. Because fewer fibers contribute to the response, the recording waveform becomes much smaller. The waveform remains relatively compact in the shape. Both the upper and lower portion shows reduced responses compared with normal panel. The figure demonstrates the axonal degeneration reduces the number of conducting fibers and leading to smaller CMAP response. In panel C, the nerve fiber remains present, but the impulses do not travel uniformly. The black dots are spread out at different positions along the nerve fibers, showing uneven conduction. As the impulses reach the recording site at different times, the waveform becomes broader and dispersed. The waveform shape changes compared with the normal pattern. In the lower portion of the panel C, the recording response is smaller and more dispersed than in the upper portion. The figure demonstrates altered transmission of impulse along the nerve fiber in segmental demyelination, producing dispersed and abnormal CMAP waveform. The panel description and the main waveform appearance. Panel A, normal nerve with large synchronized waveform. Panel B with axonal degeneration, small waveform. Panel C, segmental demyelination, dispersed broadened waveform.